I think it's important to recognize that most of us are doing the best we can with what we have. You have to invest a decade of your life just to get started, right?
Just to get started.
There's way better ways to make money if that's your goal.
Right.
Way better.
Right.
Yeah.
I wasn't in practice till I was age 32.
You have to reward people for going through that. There has to be some incentive to, it's like, hey, you want to spend a decade of your life getting started and then live with profound stress for the rest of your career, and you're going to have a positive to that, right?
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Lisa Rollison. Welcome to the show, Lisa.
Hi, thanks for having me here.
Lisa is a friend of mine, a colleague here at Boone Hospital Center, and Lisa is a board-certified general surgeon.
Indeed, I am.
Indeed, you are. When I was this tall with a short white coat, I knew I was going to be some kind of surgeon, and general surgeon was certainly one of them. And I remember one hospital I was at. It's not the University of Princeton. It's called the Princeton Medical Center. It's a hospital that happens to be in Princeton. It's a little hoity-toity. And I remember the surgeons when you ask them what kind of surgeon they were, they would say general. And it was really a badge of honor because they did everything. And I think it was all guys. They did breast, they did thoracic, they did lung, they did cancer, they did bones, they did everything.
Absolutely.
And being called general surgeon was really a badge of honor that they did all this stuff. Now, Lisa, you were born in Missouri. You did your undergraduate training at Truman.
That's
one
right.
of the great liberal arts colleges here in Missouri. I believe you did your medical school and residency training in Iowa, in Des Moines.
I did.
And like I said, you're a fully board-certified general surgeon, which means you can do almost anything.
Yeah.
Now, something I've noticed over the years is that more and more surgeons are doing fellowships and subspecialty training, and surgeons are getting a little more narrow in their scope.
That's very true.
Yeah, and I notice in your group, one of the surgeons who we've had, Dr. Peterson, she does more of the breast stuff. We've got Reggie Vaden, who is a board-certified colorectal surgeon, but still does general. You've got our first guest ever, Dr. Ben Gerber. He is general, but he does a lot of robot and what's called foregut stuff. And notice everybody kind of settles into their comfort zone. And before you came to Boone, there was a wonderful general surgeon named Shakir Lax, everybody calls him Jake, that in order to do the type of stuff he wanted to do and get reimbursed and whatnot, he needed to do a fellowship. So I think he left practice here and he went into a fellowship in East Carolina for I think at least 2 years to go back and do a fellowship in surgical oncology because that's where he wanted to go. So I'm just wondering, as a general surgeon, are you getting stuff carved away from you in any ways that's kind of impinging on your ability to work?
Yeah, that's a great question, and that's an ongoing topic in general surgery, I think. So we all have a very broad knowledge base or training base, if you will, coming through a general surgery residency. And in the past, like you say, the old school, they did everything. Yeah, everything. And I think we've learned over time that we do better when we do things in volume. If there's a particular procedure that you don't do very often, I think statistically a lot of people would argue that your outcomes won't be as good. So, along that line, we have tended to specialize. And I think people have evolved toward the thing they enjoy, or the thing. Yeah. So you mentioned my partners. We all have this. We all did a 5-year general surgery training, but we all sort of have at this point, specialized in other things. Especially, like you say, Dr. Vaden has a colorectal fellowship.
Right.
Yeah.
And I believe she's boarded in that well, so she's double boarded.
Right.
You don't have to be.
You don't. And then as the other thing that I think has made a difference is that our training has changed a bit, for the better or for the worse. The 80-hour rule came into effect, and so we don't get as much volume in training as we used to. And I think that some folks come out of training maybe not feeling as comfortable doing things as the old school did.
Yeah.
And so in order to get some more experience, they'll do a fellowship, whether that's minimally invasive or whichever specialty you go into.
Whatever it might be to get that volume.
Yeah,
it certainly was a trade-off going to the 80 hours. And I've said this I think I said this with Ben, I'll say it again.
Yeah.
What is the downside of being on call every other night? And you might think a regular person might say, what do you mean on call every other night? You never sleep. How brutal is that? And it's true. It used to be every other night. Yeah. But the gung-ho surgical trainees can say the downside of being on every other night is you miss half the cases. So a true surgical, gung-ho person would want to be on all the time and have zero life and zero sleep.
Yeah, it's true. And that's why they were called residents. And I think we all have heard, the kind of the origin story of residency. And
tell me, please.
Way back in the day, there was a particular surgeon who was on the cutting edge. He was like the beginning. We're going to have to edit some of this out. Let me do a better job. But
sure.
It was Dr. I'm on the spot now, so I won't remember.
Take your time.
Anyway, he was doing things that had never been done, and people wanted to be in his sphere to learn from him. The problem was he was on cocaine, so he was awake all the time.
Like Sherlock Holmes and Freud,
Yeah. So he was awake all the time doing work, and so that was the yardstick against which everything got measured from there forward.
Can you keep up with the crackhead cocaine addict?
Yeah. So that gentleman also took his mother's gallbladder out in her kitchen, if I remember correctly.
Impressive.
Yeah.
Yeah, and I think Freud operated on his own nose with cocaine anesthesia. Yeah, probably had some kind of cancer. Wow, these stories of the history of medicine are just amazing. They really are. The first I interviewed ophthalmologist recently, Dr. Clark. And think of the first person that put a needle in the eye to push a cataract out of the way.
Who thought, you know what, we should try.
We should try this.
Let's just get a needle and do it that way.
Let's just push the cataract out of your eye.
What can go wrong?
What could go wrong?
Yeah.
Yeah, all kinds of these incredible innovators. People had to, like the guy who realized that Helicobacter caused
Australian
ulcers.
Guy
he had to eat it. He had to
cool. I'll just drink some myself and see
he
what
had
happens.
to consume them to convince people that's what caused the problem.
They didn't believe him, of course. They never do believe people that are on the cutting edge. Well, gynecologists were the first to do laparoscopic surgery, right?
Oh yeah. Oh, I bring that up every chance I get. And I realize that as a medical student, the GYNs and some Germans in particular, I'm forgetting their names right off the bat, but they were the first ones to put telescopes in there, and they had mirrors and candles. And I am so old, Lisa. How old are you? I am so old, Lisa. We did laparoscopy. We had to put our eye down on the scope. And the big innovation was putting this metal hook over it so you could put it over your head and it would hold it there so you could use your hands. That's how old I am.
You look remarkably well for your fossilized state here.
Unbelievable.
That was a long time ago.
And just for the audience, we now have little video cameras we clip on, and now we can stand up straight, not have our head in the blood.
Well, and in the robot, it's binocular vision.
Yes.
Which is a game changer.
Yeah, the robots did. So I saw when laparoscopes first came about, I saw it being adopted by the general surgeons. One of the first places it was adopted was in cholecystectomy, or removing the gallbladder.
Right.
And when I was a medical student, once again, I'm so old, but I think it's important that our listeners realize what it used to be. In order to get a gallbladder out in the old days, and I was there because I was the medical student.
You were holding the retractor.
Liver, holding the retractor.
Yeah.
They would have to make a big incision in the skin. They would have to split your rectus muscle, your 6-pack was now a 3-pack.
Yeah.
Make this big hole and then try to operate in the gallbladder way down the bottom.
It's true. Very painful thing to go through.
Very painful. I remember this one guy's gallbladder was dying, and the resident told me, you're going to see an infarcted gallbladder. I remember way down in the hole, I'm holding this retractor, was this black, inflamed mess of a gallbladder because it was so hard to get to and diagnosis was frequently delayed. So let's start, Lisa, by one of the surgeries you do a lot of. And you and I operate, I'm in room 6, and I think you're in room 5 or what.
Yeah,
so we're
neighbors.
We're neighbors. We dictate our cases. Yeah, every Wednesday we're neighbors. And boy, I've never seen such a parade of laparoscopic cholecystectomies as the cases that go through. So you do a lot of these. So this is clearly something you have a lot of experience doing. You have those coveted case numbers. I think you're doing about 200 a year. And the time, I'm sure the time goes down. You can do them quicker and quicker and more efficiently. So let's talk about the world of laparoscopic gallbladders. Now it's not a big incision. It's 3 or 4, maybe 5 little tiny holes. And you can get in, do the work, and get out without causing all this trauma getting in there. So let's talk about the gallbladder, Lisa. What does the gallbladder do in the body?
You know what, Gil? Why don't I draw you a picture?
Would you like to draw me a picture? I would love for you to draw me a picture, Lisa.
Yeah. So I will give you the same spiel, if you will, that I give my patients.
I would love that. I have a whiteboard here and a marker.
Sounds good.
And I would love for you to knock yourself out showing us what a gallbladder does.
All right. Okay, so in our right upper belly. Okay.
Right upper belly.
That's where our liver is. And again, I'm drawing this backwards, so liver. And among many jobs the liver has, it makes bile. And that bile gets directed down into your intestine.
Okay.
Right as it comes out of your stomach there. Okay, so here's your bowel. We'll call it the bowel.
Okay.
Your pancreas is tucked in here. This is your bile duct. And then your gallbladder has its own little duct that lives here. And gallbladder itself is up under and attached to your liver.
Okay.
Okay? So under normal circumstances, that bile gets created in the liver, gets stored in your gallbladder until you eat. And then the gallbladder squeezes and sends that bile down into your bowel so it can help do its job.
And mix with your food.
Correct. Helps break down, especially fatty food.
Okay.
Which is why a lot of times when a person eats a fatty meal and they have gallbladder disease, they'll have pain.
Ah, because that's one of the signs you may have a gallbladder problem. Eat a fatty meal, get some pain. Is it usually right there?
It can be, a lot of times. Everybody's a little different, but usually in the upper middle of our belly, right upper belly, radiating around to your right back.
Okay, so it's around here can be gallbladder pain.
Yep. Some people feel like they're having a heart attack.
Oh.
Yeah. And
that'll get your attention.
Yeah, some people have no symptoms at all. Especially I've noticed in like a demographic of maybe older males. They come in for some reason, they're just not feeling well, whatever. And we find out that they have a gangrenous gallbladder.
Ooh, it's dead. That is a medical emergency, folks.
Yeah.
This is a great diagram. So the bile comes down, gets stored in the gallbladder, and then gets squeezed out in response to a meal usually.
Right. And the tests we do to check into this, we have lab values that we look at. We have, especially our liver function tests. Yeah.
Okay.
We have ultrasound, which gives us a physical picture of the gallbladder.
Okay.
Is it enlarged? Is the wall itself thickened? Is there fluid around the gallbladder?
You can see these on ultrasound.
You sure can. You can see the gallstones. Yeah. So that gives us some information. And then there's also, let's say we do your ultrasound and it's normal. Everything looks fine.
Okay.
Well, then the next step that we have is to check what's called a HIDA scan. And what that does is check the function of our gallbladder.
How does that work, please? I've heard of HIDA scans. Please explain it to me.
Of course. So the patient has a material injected into an IV, and the gallbladder basically absorbs that up out of the liver absorbs it up out of the bloodstream and secretes it into the bile. So now the vial contains this tracer material, okay? So then they watch, during the test, they'll watch the gallbladder fill up with material.
Is this radioactive?
Mm-hmm.
So it's a low energy radioactivity, very safe.
Right, very safe, very safe. Then they'll give the patient something, whether it's in the IV or by mouth or whatever, to make their gallbladder contract. And that's when the real fun begins, Does
that hurt? What do they give? Do you know what they give? Is it cholecystokinin?
I've heard people say just cream. I've heard all kinds of different things.
So kind of something, a fatty stimulus.
Yeah, it just depends where you are.
So it's not glucagon. All right.
So then they're able to give us a number called an ejection fraction.
I've heard that in the heart, how much blood's coming out per squeeze.
So if 100% is what we started with, after that stimulus, how much fluid got squeezed out of the gallbladder? That's your ejection fraction. So normal is about 35% roughly.
Okay.
Yeah. So if you come out with a 0, then clearly that's abnormal.
That's no good.
Sometimes, and it's debatable, there are people that would argue either side of this, but some people that have a really high number, there's some suspicion that could be an issue too.
Oh, interesting.
Yeah. And I like to know, I'll say, hey, did you have pain? Did the symptom that you tend to have get reproduced with that HIDA scan?
Gotcha.
And if the patient did have the same pain, then that gives me a clue that even if the test is normal, there's a chance that if we remove the gallbladder, their pain will go away.
Gotcha. Yeah. Right. So Lisa, you discussed what you can see on sonogram. You said you can sometimes see stones.
Indeed.
Where do stones come from, and where do they fit in this?
Yeah. So often people have gallstones, which are just like exactly what it sounds like, stones that form in the gallbladder. And if you think about a glass of water with salty water, and how the salt precipitates out as the water dissolves away.
Yeah.
It's the same concept in the gallbladder.
So these crystals form, they start small and they get bigger and bigger, huh?
That's how they start though.
Okay.
And so they can, if we see gallstones, we know things aren't working perfectly. Okay, there's probably a problem there. That said, some people go through their life with no symptoms.
Carrying stones.
Yeah.
Like little pearls. They just carry them and they do just fine.
They do just fine. But here's the deal. These stones can get caught, say here, in this general area, and make it so the fluid can't get in or out of the gallbladder properly. And that can cause pain. That can cause what we call acute cholecystitis, which that person needs their gallbladder out fairly shortly.
So they've got a blockage. Is that going to hurt usually?
Oh, yeah, it's very painful.
Oh.
So then these stones can also travel and block this duct, right? And if that happens, the bile can back up into the liver, cause serious problems. If the stone is down here and affects the pancreas, it causes what we call gallstone pancreatitis.
That's not good.
Which is a very painful, and then gallstones are one of the most common cause of pancreatitis.
Pancreatitis.
So, yeah.
Now, the pancreas has digestive enzymes in it, right? So if it starts to leak, it can cause horrible damage, can't it?
Absolutely. Yep. So that's where our friends, here at Boone, we're lucky enough to have GI colleagues that can do what's called an ERCP.
What's an ERCP?
That's a great question. So that's when they use an endoscopic approach. So they'll put a scope down into the bowel here.
Through the mouth, esophagus, stomach, into this loop of bowel here.
And then they're able to go up from below and get the stones removed and do the thing they do to keep that area open so that it doesn't scar down and cause more trouble.
How do they do that?
Yeah. Well, they'll put a stent.
Imagine a stent. They can stent the bile duct?
They stent it. They make what's called a sphincterotomy, which is a tiny little, incision right there. That can make that area a little bigger so that the stones have an easier time getting out.
I'll be darned. And I think we had Kevin Halsey, I think, is one of our local
you should invite him to come discuss. He's a busy man.
He's a busy man.
We have people come from Iowa, from very southern Missouri, from all over the place, because it's hard to find a place that has ERCP capability and guys like Dr. Halsey.
Well, I know there was one guy in St. Louis. He was the only guy in town for a while. Forgetting his name, some Italian name. So Kevin's busy guy.
Indeed.
So they can get these stones from below as well.
Yep.
And maybe save the gallbladder or save them some pain or whatnot.
So what we do during surgery, let's say here's the ribs.
Okay.
belly button. So we put a tiny incision above the belly button, and we actually inflate the belly. That's the basis of laparoscopic surgery there.
Right.
And then we put a few more incisions, and we're able to put clips on this gallbladder duct right here.
Okay.
And then we remove the gallbladder, and we bring it out a small opening right about here.
So you can pull it out also through another little hole.
Yep.
Now, I know enough, Lisa, to know this area of the anatomy is very complicated. There's arteries here,
Indeed.
veins here, and everybody's different. As
right.
if it weren't complicated enough. There's
That's right.
variations.
Yeah, so in a nutshell, we have a thing we do called the critical view of safety, okay?
Okay.
Yeah, and it's a technique we use when we dissect the gallbladder out, that we get it to a point where all that's left is that cystic duct that we see connecting there,
Okay.
the artery, and everything else has been dissected free. And that helps us avoid a common duct injury. Yeah,
Okay.
yep. But you're right. Some people basically don't have a cystic duct, or their gallbladder sits very close to this big duct. Some people have, their arteries don't follow the textbook.
Right.
You'll see all kinds of different anatomies. Yeah.
So you have to, so that's another instance where your experience, having seen hundreds of these cases, you're saying, oh yeah, 5% of the time, oh yeah, I've seen that funny artery before, that funny gallbladder junction before.
But if you see that anatomy from the front and the back, then it's very, the odds of you having a serious injury are very low.
Okay, so if you've come up with best practices and ways to approach this, because I remember in the beginning when they first started doing these, there were many different techniques.
Yeah.
Some guys were pickers; they'd pick away, and then some people used J hooks, and some people use. I could name all these different instruments, but it seems that you've all kind of converged on the fastest way to do this.
And lately, like within the last couple of years, we have acquired technology here that allows us to use a material we'll call it ICG for short. And what that does is, you remember how we were talking about the liver absorbing the material during the HIDA?
Okay.
So that it does the same thing with this different material and secretes it out in the bile. And with the camera we use, it turns green. So when you turn the setting on the camera for the ICG, the liver's bright green, and if you can see the ductal system and it has bile in it, because sometimes if you have a stone stuck, your gallbladder might not fill and become green. But it's another tool we have to help define our anatomy and keep people safe.
I think it's isocyanate, something like that.
Yeah. So that's been terrific. That's been terrific.
So it helped you be even safer.
Yeah, so I just use it routinely now.
Gotcha.
Yep.
So what criteria do you use to take out a gallbladder? Now, I assume since it's easier to do and it's so safe to do, I assume your criteria are getting maybe evolving. Or maybe do you take them out sooner now, do you think?
Yeah, I think we definitely take them out sooner. I mean, I feel like anyone that has documented gallstones or a gallbladder abnormality and has symptoms, they're very eligible to have their gallbladder.
So they're a ticking time bomb. If they've got gallstones, if they're not in trouble today, there's a high likelihood they'll get into trouble? Yeah,
over the course of a lifetime. And, there's some continuum there, too. If you have a little 92-year-old lady that, we see her gallstones on an x-ray, she has no symptoms, you're going to leave her alone.
Leave it alone.
Yeah. But
but we do a similar thing in GYN. I do a lot of surgery for endometriosis. And if a woman's got significant endometriosis, we take out her appendix just so it won't be involved, or maybe it is involved, or if she has pain in the future, we know it's not the appendix. So
that's the thing. Sometimes we have people with symptoms that are vague, and perhaps their testing is equivocal. It's not significantly positive, but their symptoms sound like it could be the gallbladder. This is a safe enough thing to go through that under those circumstances, sometimes we'll take the gallbladder out to remove it from the equation. Okay?
Gotcha.
So now if you continue to have problems, we know it's not. That's not what it is.
It's not the problem.
Yeah.
Now, how does one's life change after the gallbladder is out, if it's not there to squish in bile during a meal, what happens to the bile?
Yeah, so the bile basically just trickles down into the bowel,
Constantly.
Yeah, it's not getting held there in a bolus coming out at mealtime, but most people adapt and do, and barely know it's gone, barely notice. But some people do get, it's true, some people get some loose stool or some symptoms after meals, but most of the time that gets a lot better with time.
Gotcha. So the body adapts. Now, would one way to change how you eat, maybe eat smaller meals more frequently? Is that a strategy?
That might be helpful. Yeah, it's very different. Everyone's individual. Some things that work for some people are of no help at all for others. And
So people figure out kind of what works for them,
right?
What foods bother them and whatnot, and can usually make adjustments.
Absolutely.
So, what would be a rough complication rate? If your doctor says you've got some symptoms, you have some symptoms, you go to the doctor, they do their HIDA scan, ultrasound, find some stones. Let's say the person's basically healthy, maybe a little overweight.
Yeah.
What would you quote this prospective patient or this prospective candidate for the surgery? What would you tell them the complication rate might be?
Well, it's well under 1%.
Under 1%?
Yeah.
That's fantastic.
So some complications include bleeding, an infection or abscess, having a bile duct injury, thing called and that's probably the most serious thing you can have, a duct injury. A retained stone, where we have a gallstone or a stone in a place that doesn't get removed with the gallbladder, and later on finds a way to cause trouble.
Now, are there ways to look for that during the surgery?
Yeah,
How do you do that? How do you do that?
If you you can do a cholangiogram, which basically is a radiology test that's done during surgery to look for signs of a stone. I don't do that a lot anymore because I'm limited in what I can do to resolve that problem. And we have access, where I work, we have access to ERCP. So I feel like they can do a better job with that issue. However, if I worked out in the rural setting, and it was very difficult for a patient to get access to ERCP, and I needed to address that situation, I might do it differently.
I see. I see.
I used to work in rural Missouri. Yeah, and it's just a different job, a different existence.
Yeah, and a different way of managing things. For example, I remember studying for my boards and figuring out what am I going to say, because how you evaluate and manage an ectopic pregnancy in a big city where you're just a few minutes away and everything's there is very different from someone who's hours away in the agricultural area.
Yeah.
It's different.
Yeah, they don't get enough credit out in rural America. They don't. The resources that I used to work in a hospital that had a tremendous amount of resources for a small hospital.
In Des Moines or?
No, in Northeast Missouri, where I'm from.
In Still or Truman, or where would that be? Northeast Regional?
No, I was at Scotland County Hospital, which is in Memphis, which is my hometown.
That is a small town.
Yeah. I worked there for about 7 years.
There.
And so, a general surgeon in a small town like that is doing C-sections and, basically anything that needs to be done that you have the capacity to do.
True general.
Yeah.
True general surgeon.
Not to the point where you're doing, triple A's and Whipples like the old school complete general surgeons did. But you do have a little more bandwidth than you would even hear. Because, I used to do vasectomies, but guess what? We have lots of urologists here that do vasectomies, so I don't do those anymore. I used to do tubal ligations, or actually I resected the tubes when I found out that that's maybe the standard of care. I haven't followed that, I'm sorry.
Yeah, that's okay.
But I used to do those.
And C-sections.
And C-sections, which usually they were emergent C-sections because I did them when I was on call, right?
Right.
Yeah, so it's a different gig. Yeah.
Right.
And it's enjoyable because of the variety, but I do enjoy there's fewer things that I do now more frequently, And I find a flow state when you're doing things quickly and efficiently, but
Yeah.
doing them very, very well.
Gotcha.
Yeah.
Yeah. In my training, I was always proud I could do a really good C-section in 13 minutes. Skin, what they call skin to skin,
Yeah.
done, and do it right.
Yeah, yeah.
And I could probably limp through one now in about an hour, you know.
No, see, you'd have some muscle memory that would kick in.
It'd probably be something that would kick in.
You do
In
fine.
a rural area, in an emergency, you
Yeah.
could probably do it.
Yeah.
Yeah, but I'm going to say this again. For a lot of surgical procedures and a lot of cases, the more you do, the better.
Mm-hmm.
I know that's been proven in heart transplant places. When hospitals are inspected, they look at infection rate after hysterectomy. That's one of their favorites.
Mm-hmm.
Another is management of pelvic fracture.
Yeah.
Apparently, pelvic fractures are very complicated,
Right.
and you find 5 of those for a
Right.
hospital, you get some idea how they're
Yeah.
doing.
But on that note, we really shouldn't judge too harshly because we don't all have the resources to do a lot of everything.
Right, right.
There's
limited time,
Yeah. Yeah. So I think it's important to recognize that most of us are doing the best we can with what we have.
I think that's so true.
Yeah.
I mean, you hear about a greedy doctor or
Mm-hmm.
somebody does it for the money. I've yet to meet them. I'm going to go out on a limb, Lisa, and say 99% of us, doctors and nurses and people in healthcare, are doing it because they want to help people.
Yeah, I mean, you have to invest a decade of your life just to get started, right?
Just to get started.
There's way better ways to make money if that's your goal.
Right, right.
Way better.
Right.
Yeah.
I wasn't in practice till I was age 32.
Yeah. And I think you have to have some, you have to reward people for going through that. There has to be
Right,
some
yeah.
incentive to, it's like, hey, you want to spend a decade of your life getting started and then live with profound stress for the
Right.
rest of your career, and
Right.
you're going to have a positive to that, right?
Right. There has to be some,
Yeah.
some goal, some target, some reward.
Mm-hmm.
So Lisa, you're very good at gallbladders.
Well, I
You-
mean,
you
that's-
probably do more than anybody else at
I'm
our
sure
hospital.
there's somebody out there that's faster and more.
Oh, there's always
But-
somebody. Yeah.
Yeah,
I mean, you learn this at conferences. You post you present a study with 20 people with a certain and always somebody in the audience gets up and says, "Well, we did one with 2,000
It's
people."
like, good for you. Way to go.
There's always somebody bigger, stronger.
That's right.
So
I do
when-
enjoy it, though.
Yeah,
It's
yeah,
nice to, people really appreciate it when they have a problem that keeps them from doing something as basic as eat without
Yeah.
trouble. And, they go through this and feel so much better. So that's rewarding for me.
Yeah. And I also see you do a fair number of hernias. Now, hernias are out pouchings. There's some classic weak areas of the abdomen
Right,
where
it's
hernias
true.
like to come. One's the belly button.
Absolutely.
And I think people with outies may have been during infancy or even in utero, they may have had a little pouch and it's kind of gone in a little
Yeah.
bit, but there's a little natural outie pouch. It's called an umbilical hernia that can be enormous. And there's also areas in the groin
That's right. Those
Where-
are two very common places for
where
hernias.
there's weak spots.
Yeah.
So you will help treat hernias in people. So tell me about hernias of the belly button. When do you know you have one?
Yeah.
And when should something be done about it?
Yeah. So the thing about any hernia is that the tough layer of our abdominal wall where a lot of the strength is, when that area gets a hole or an opening or severe weakness, what can happen is our bowel can go up through that hole and get twisted or pinched, which we call a strangulated bowel.
Oh, well, that doesn't sound good.
No, it's not. And usually within hours, it can cause a situation where that piece of bowel needs to be removed.
Because it's dead.
yeah.
It's strangled.
It's strangled.
Oh.
Yeah. So some people, it's kind of the same concept as the gallstones. Some people are going through life with a hernia. They're having no problems, and they may never have a problem. And if we had a crystal ball and could look and see, will this become a terrible problem or not, that would be super, but we don't.
We don't.
So yeah, if people have pain or the bump that's coming up through, we call that the hernia sac. If that area is getting bigger over time, it's good to at least have a conversation about whether a person wants to have it fixed or not.
Yeah, now when you push it back in, that's called reducing the hernia, right?
That's right. You got it.
Now, I think there was an old school, I don't know if they still use them anymore, something called a truss.
Oh, yeah. They're out
Do
there.
people use trusses anymore? And it was like a hard thing, a little round point, and you put it on there and put a belt, and it would just hold the sac in.
Yep, it does. People use them, and they can do very well.
And they can be down the groin, too. We're going to get to those kind of hernias in just a second. So you can just have a truss that holds it in, and
they go about their business.
You go about your business.
Yeah. Yeah, it works. For some people, that's all they need. That works fine. And it
works fine.
Yeah, and the odds that they'll have a problem, it's still not zero. But if that's how the way I see it, if you give people information and they feel they are informed, they can make a choice as what they want to do. If they come in and listen to what it involves to have a hernia fixed, I'm like, you know what, that's not for me. I'm just going to go ahead and I'll take my chances. And if I have a problem, I'll come in. And I understand that, if I have to have that surgery under emergency circumstances, my outcomes, my risk of lots of different things might be higher, but that's okay. I'm all right with that. That's great. Good for them.
Right. It's called autonomy.
Yeah.
You have to respect that.
But most people, once they hear the risk and they're having some symptoms, they're really wanting to have that straightened out and fixed.
Yeah, I tell people all the time, you don't want to have an emergency at 2 a.m. on Saturday night, Sunday morning.
Which is always when it happens.
When it happens.
And then half the time the patient's on blood thinner, which complicates things. We are evolving, but I like to do most of my hernia repairs either laparoscopically or robot assisted. Okay. And, until recently, we didn't have robot access on the weekends or after hours.
Really?
Yeah, so that's evolving.
Because you need a team. Let's explain this to people. It's not that the robot's not there.
Yeah.
You need people to set it up, take it down.
You need that expertise. And it's like anything else.
It's a big deal.
It's, it's a tool that requires knowledge to manipulate and run, but it's not, it's very knowable. It's not, any nurse can learn to use it.
Sure.
But you just have to have that training.
Right.
So, but yeah, and again, one thing that's frustrated me about some meetings that I've been to over the last few years is that it's very robot-centric. It's like, here's what we're doing.
Yeah, that's the way. I still use what are called sticks. I mention this all the time. I don't have time for a stinking robot. Yeah. We got these long instruments, we call them sticks, and I do.
And for what you do, that works just fine.
It works just fine.
Yeah. And I have in a straightforward groin hernia, I still am very fine with laparoscopic approach. I don't feel that I gain that much or my patient gains that much with the robot. But does the robot work? Is it effective? Absolutely. If I have access to it, I'll use it. But what I don't want is for the patient to wait 6 weeks for a robot surgery that I can do just as well 2 weeks from now.
Gotcha.
Yeah.
So that's the perfect segue. Let's talk about these hernias in the groin. Would you describe them? Girls can get them. Guys can get them.
Anybody can. Yeah.
And tell me about them.
So like we talked about earlier, when that tough layer of our abdominal wall gets a hole in it, again, anything in the area can come through the hole. Sometimes that's fatty tissue. Sometimes it's bowel. Sometimes it's the appendix.
Yeah.
So if you're really, really unlucky, you'll have your appendicitis in your hernia. So
these things happen.
It happens. Not very often, but it happens.
Now, are guys a little weaker than gals because our junk comes through these tunnels?
Absolutely. Well, I mention that to patients. I say, well, when you're developing, before you're even born, your testicles started in your abdomen.
And they had to come down.
Right. So the path they follow, your body closes that in afterwards, but it's always a weak area. Okay. Yeah. And so, so the pressure, wherever the pressure goes, the tissue will follow. So in a guy,
that makes sense.
Like this person has a scrotum that now is full of bowel because the pressure pushed and pushed and pushed.
I've seen those, folks, and it's just for our listeners who aren't seeing. Sometimes the scrotum can be this big, and it is moving because there's bowel in there. Yeah. Moving around, and
but you know what? We can fix I can fix those laparoscopically still. We have ways.
How to explain? How can you fix a big, huge bag of generally small bowel, or it could be your appendix? How do you put that back in? Right. Tighten it up, get rid of the bag. Tell me how you do that, you amazing general surgeons.
And again, there are no absolutes. There are some exceptions, and I even had one of those recently where the bowel, the colon was so severely stuck where it was that typically we're able to gently coax it out, pull it out of the hernia.
And from the inside, so you put a telescope in the belly.
Right.
You've got this big hernia sac, and you're literally...
You can see it going up through the opening or the hole.
And you're pulling the bowel out.
You pull it back out.
Yeah. Okay.
Yeah.
So now the bowel's out. Now you've got an empty, floppy sac.
Right. So
now what do you do,
doctor? So what I do is I make a small incision in the inside lining of the belly called the peritoneum.
Okay.
Very thin layer. And we make a flap or a pocket down toward the groin where the hernia is.
Okay.
We get that all cleared out. And then, for most folks, we just go ahead and put a mesh patch down there.
Put a patch, just cover up the hole.
Yeah, yeah.
Okay.
And it's got, the one I use has this nice 3-dimensional shape. So it just fits right down in there perfectly. And you cover the whole area so that your risk of having a hernia come back is lower.
Okay.
Okay. So once you get it fixed, what I do is I fix it into place with either a suture or an absorbable tack.
An absorbable tack. I remember years ago they had these little coils and stuff, and it would hold it down, but they would stay there and invade into the nerves and cause pain.
And there's a lot of people in the world that have no problem with the tacks, but sometimes if they get up against a tiny nerve or are problematic, that's an issue that's not going to go away because the tack is not going to absorb.
But you have absorbable tacks now.
We do. Absorbable tacks. So what they tend to do is they'll hold the mesh in place while the body heals into it, because the mesh, it's literally a mesh. It has tiny holes all through it. So the body just grows into it. Yeah.
So it gets becomes part of you, integrated into you, and it's not going to move at that point.
Right. It's
so
part of your abdominal wall.
So the tacks can dissolve, and if they're hitting a nerve, they're gone.
Right.
And you have what we call a durable repair.
That's correct. Then when we're done with that part, we take the flap, the tissue we started with when we made our pocket, and we put that back up over the mesh so that it's not in direct contact with the intestines. And that reduces the odds that a person will develop scar tissue or what we call adhesions that will later on be a problem.
So these early mesh procedures have evolved.
They have.
So now you don't have the bowel sticking to them and having all these complications.
And again, there's always a risk, but it's lower.
Okay.
It's lower.
All right. Well, since you were doing so good on gallbladder complications, let's say a patient comes in, maybe a little overweight, otherwise healthy, not a horrible chain smoker or anything. What kind of complication rates would you see from an inguinal hernia?
It's still very low. I mean, maybe 3%.
3%.
Yeah, and that's all things. Like,
right.
So the risks would be bleeding or developing a hematoma or a
collection of blood. You bleed into it. Okay.
Yeah. And that's rare, but it's possible. You could have an infection, which you could have a small infection in your incision, which kind of is self-limited.
Okay.
On the other end of the continuum is if the mesh gets infected, and we have to, at worst, take that mesh out and start over. Now, that's a rare problem, but it's a very serious one. Yeah. And then the other thing that's common, or not common, but that I always tell people about are recurrences, having the hernia come back. And technically, I do things technically in a way that I hope that the repair stands up to any abuse you can give it. But there's going to be some people that the hernia recurs.
Okay.
Yeah. I find that we know that people, and I'm talking all hernias, not just groin hernias.
Okay.
But if people are smokers or nicotine users, if they're diabetic, if they have a lot of pressure in their belly, usually that correlates with having a high BMI or body mass index.
Being overweight.
Yeah. So all those things are factors that make it more likely that the hernia will come back someday. And there are some cutoffs that we say, hey, if you're, like, for instance, BMI. If you have a BMI over 40, your risk of a recurrence is very high, no matter what we do.
All right.
So lots of times we'll have people will choose to go ahead and try to get their risk factors optimized or in the best shape they can be, get their diabetes under better control, stop smoking, do whatever they need to do to lose some weight. And then we're in a better place to fix the hernia.
Or you find, this is kind of an aside, I wasn't planning on asking you about this, but these new GLP-1 injections, these Wegovy's, Ozempics, all the different names, are you finding them helpful for patients to lose weight quickly before a needed procedure?
They're very effective at losing weight. Yeah. And it's not unusual for me to refer a patient to the bariatric center so that can be discussed. Yeah.
Gotcha.
And I don't prescribe them myself. So, I can't talk about numbers or risks and benefits, but clearly, just anecdotally, we can see that they're very effective.
Yeah. Another aside on the aside, it's very important that they stop those injections a couple weeks before surgery because their stomachs.
Yeah, it slows down your gut.
Yeah, you don't want to have a full stomach when you're having surgery.
Because we don't want people to aspirate or have material that's been in their stomach, and we would have expected it to move on, but it hasn't. We don't want that to come up and then go down into the lung and cause an aspiration problem.
Big problems, big problems. So, Lisa, I mentioned your operating room is next to mine, and sometimes when I'm scrubbing, I know I'm breaking the rules, but I'll walk into the room, I'm still scrubbing, and I'll look over your shoulder, I'll look on the TV screen, see what you're doing, try to learn something from you. And I did that just a few days ago, and you were working on a very interesting problem. Patient was on their tummy. They were butt-up presentation. And this individual had something called a pilonidal cyst.
Yes.
Pilo means hair, nidal means nest. So tell me, what is a pilonidal cyst?
Yeah, well, it's a frustrating problem for people. So it's basically a space that tends to form at the top of what we call the gluteal cleft.
So right above the upper part of your butt crack, right around your tailbone.
Right, exactly.
What an uncomfortable place.
Yeah, it's awful. So they tend to, you have a space there that fluctuates in size and content. It might be completely flat for a long period of time and you have no problems. And then it might start to collect fluid or get infected, and now it's got pus in there. And maybe under an emergency, it has to be opened up to drain. Right?
So this could be an infected pocket right around your tailbone, your buttock area, and they can be chronic and just can really.
So when we do an excision, what we do is we make usually an oval-shaped incision around the problem in the skin, and we go down underneath that pocket. So most of the time we go all the way down to the tailbone. So it results in a fairly sizable wound, right?
This big hole.
And it's in a place that we don't have a lot of laxity in our tissue. Like talk about the back of your arm or somewhere on your body that it's easy to pull that tissue together.
Right.
But in that area, it's a little bit harder. So let me just say the surgery is the easy part. That's that's easy to do. It's the healing that's the challenge. So I tell people that, if they go and Google this, you're going to find many, many different techniques on how to repair or how to do a pilonidal cystectomy. And that's because none of them work very well.
Right.
Okay.
I've said this before elsewhere. The reason we have consensus statements and consensus meetings and whatnot is because there is no consensus.
There is no consensus, yeah.
Right.
So, first of all, when I visit with a person that has a cyst that's not very problematic for them, maybe it flares up minimally once in a while, I'll say, you know what, let's just watch it. Let's watch it.
You give them some antibiotics or some topical wipes or something?
Yeah, and usually with their rare flare, we can get that under control with an antibiotic and they live their lives. But if it's affecting their life, if it's painful often, if it's draining and it's obnoxious to deal with, then it's time. Let's go take it out. But here's the deal. I have my patients leave their sutures in for 14 days, 2 weeks, and then when we take them out, there's still a pretty reasonable chance that area is going to open back up again to some degree.
No.
And then it has to just heal on its own. Maybe sometimes we have to pack it, sometimes we don't. But so it's a troubling thing to go through.
True pain in the ass.
Absolutely.
And so
then
that's
the real kick of it is that it can come back again someday.
Yeah. Yeah, I've heard it's a very frustrating thing to treat.
There are things in general surgery that are rewarding, and this isn't one of them.
That's not one of them.
Yeah.
Yeah, that was another thing about general surgery. And I don't want to get into it here because I don't think it's a bit. But there are, let's say, the less glamorous things that can happen to the body.
Yeah, none of it's glamorous. None of it.
Okay.
Yeah.
Okay. I'm okay agreeing with that. Let's just say some are easier to deal with, let's say.
That's very true. Yeah.
Let's say that. Good. Now, general surgeons are also trained to go in and take out bowel and put bowel back together. And do you ever now? Those can be emergencies, and I know I have to cover the emergency room every so often. I have to cover the emergency room for what are called walk-ins or uncovered patients or what is the term if someone doesn't
unassigned?
have unassigned? Right? Yes, they don't have a doctor. They have a GYN problem. Even though I'm a fertility doctor, it's my.
I didn't know you took call for that.
I take GYN call.
I had no idea.
I do for a whole month, and usually I will get a basketball-sized tumor. Somebody walks in, they thought they were overweight, they've got a basketball tumor or something.
That's wild.
I still have to remember how to take care of those.
Yeah.
Those things. Now, I don't do OB, even though I'm a trained OB. I don't have OB insurance. I don't do OB. I'm not qualified to do OB anymore. But yeah, I take GYN call. Now you take general surgery call.
Indeed.
So anything that walks in, an appendix, gallbladder, trauma.
We don't do trauma here. But yeah, it's true. I'd say the majority of our call cases are, like you say, bowel issues, obstructions, perforations, which means that somewhere in the bowel or the stomach there has a hole has developed. And there's air and stuff coming out.
That is life-threatening. Inside our belly should be sterile.
Right.
And inside of our belly and our bowel, it is not sterile.
Yep.
So you see life-threatening problems.
A fair amount of appendicitis. People with abscesses that need to be drained emergently or urgently.
Yeah, pockets of infection. You can't just give antibiotics. You need to get the infection out.
Right. And that's evolved through the years too. Now and here at our institution, we have the luxury of having interventional radiologists who, there are people who have patients who have an abscess that they would have had to have a major surgery and probably a colostomy and, some more like intense therapy where now we can get that area drained. We can put the radiologist will put a drain in that fluid collection and let it evacuate and get the patient some antibiotics, and they can go forward and have things treated more electively.
Gotcha, and save that risk.
Yeah.
Yeah, we had Max Lassinger on just a few days ago talking about interventional radiology and how it's. By the way, he did 2 years of general surgery and realized, gee, this interventional radiology may be able to treat a lot of these otherwise surgery patients.
Yeah, they do so much. Their knowledge base is so wide. They're really crucial, to patient care.
Yeah, they help all of us. They help all of us.
And that's the thing. We're all a piece of a puzzle, right? It's like we all depend on each other.
Yeah, that's why being at a hospital such as ours, where we have a community where we can all help each other and all have a expertise and the ability for us just to get on the horn and call each other for advice is really priceless and very valuable to our patients.
Indeed.
Yeah, indeed.
Yeah.
So, Lisa, is there anything else about general surgery as far as procedures you do that you think might be of value to our listeners that you'd like to mention today? Because, by the way, I am going to have you back to talk about many other interesting topics.
Really? What are we going to talk about?
Maybe the politics of medicine.
Oh, that would be cool.
And it may not be politically correct, but I would really like to hear what it's like being a woman in medicine, particularly in what is still a male-dominated specialty of surgery. Now, in OBGYN, women are becoming the majority of the practitioners, the majority of the residents are women. Men are and maybe that's really appropriate. But I know it can be tough for a woman in medicine, and that might be might be of value to talk about. We'll see. You don't have to, but I'd be interested in perhaps delving into that a little more.
Absolutely.
There's so much about insurance and payment and policies and government regulations. So there's so many things that affect our lives and our ability to practice medicine. So those are some little teasers about what we might talk about in the future.
Yeah, that'd be fun.
But while we're wrapping up this wonderfully informative conversation, is there anything more that you do in general surgery that you think might be valuable for our listeners to know about?
I can't think of a specific thing but just maybe to encourage young people to learn about general surgery. We're going to have a huge shortage.
This is crucial. Just say more, please.
Yeah. I mean, it's not an easy lifestyle, what we do.
Right. It's not easy.
People don't, plan their bowel perforations. They come in the middle of the night on weekends, holidays, So it's not an easy way to live your life, but it's very rewarding.
Yeah.
And, with the population is aging. General surgeons are like we talked about in the beginning of our conversation, like evolving towards specialization where they're choosing not to utilize these skills. And, there's going to come a time where it's hard to find a general surgeon that can do all the things that need to be done.
Yeah.
So I think the time of the jack of all trades maybe is the pendulum is starting to swing back toward that. But we need people to come and learn about it and gain the skills and go out in the world and take care of people.
Make it a better place. So it's hard work, but boy, it's rewarding. And if you want to help people one person at a time, being a general surgeon is one way to do that.
Indeed.
Well, indeed. So, Lisa, what a pleasure talking to you. Yeah. Thank you so much for being my friend and my colleague.
Well, likewise.
And taking time out of a weekend day
to
spend time with us and to help our listeners and our viewers learn more about this very important piece of the puzzle of medicine.
My pleasure. Thank you. Be glad to come back anytime.
Thank you.
Yeah.